Good morning, everyone, and welcome back to the Division of Mental Health and Addiction INARMS Symposium, celebrating September Recovery Month. We are now joining into Day 1, Session 2, and a bit about our sponsor, INARMS. INARMS is a fully integrated global biopharmaceutical company developing innovative medicines in the fields of neuroscience and oncology. Medication is considered one of the gold standards for the treatment of opioid use disorder. Vivitrol, an INARMS product, is one option. Vivitrol, the branded name, generically is known as naltrexone for extended release injectable suspension, is a once-monthly medication for the treatment of alcohol dependence, as well as for the prevention of relapse to opioid dependence following opioid detoxification. Treatment with Vivitrol should be part of a comprehensive management program that includes psychosocial support. The INARMS Symposium thanks INARMS for its stakeholder sponsorship. Now back to our MC Blake Wood for the session introduction of our Session 2 speaker. Blake?
Thank you, Sunny. This session is entitled The Silent Grind, Firefighter Behavioral Health and Peer Support, PTSD and Suicide Prevention of First Responders. Our presenter is Captain Brandon Dreiman. Captain Dreiman is a 19-year veteran of the Indianapolis Fire Department, where he serves as the coordinator of firefighter wellness and support. He travels the United States and Canada lecturing on behavioral health topics and is an IAFF peer support master instructor, assisting fire departments with creating peer support programs. Captain Dreiman is also a certified addiction peer recovery coach and a certified recovery specialist with a substance abuse endorsement in the state of Indiana, and he is also a registered yoga teacher. Having published multiple articles about fire service peer support, firefighter suicide, first responder behavioral health, and alcohol use disorder in the emergency services, Captain Dreiman has extensive experience researching the topics that are relevant to the wellness of firefighters in North America. Captain Dreiman, we'll turn the floor over to you, and we're looking forward to your presentation.
Well, thank you very much, Blake. I appreciate that introduction. And thank you everyone for being in attendance today. It's really an honor to present at this year's INARMS conference. I'd like to start off just by noting that, I appreciate that this can be maybe somewhat of a limited scope, looking just at firefighter behavioral health and peer support. But I know that one of the things that we're trying to do, particularly in the peer support world, is get away from the silos that we find ourselves in and try and broaden what can we learn from each other? What can this discipline learn from that discipline? And I hope that this goes some way to doing that, that by looking at what we're doing in the fire service, are there things that other areas of behavioral health, substance use disorder, things like that can learn from what we're doing in the fire service. I give a little bit about my background since this is about recovery. I am a person in long-term recovery from alcohol use disorder. I, as Blake mentioned, am a 19-year veteran with the Indianapolis Fire Department. I had 10 years as a volunteer firefighter before that. And I also worked for private and county ambulance services as well. I got my start in all of this when I was 16 years old. And at 16, one of my very first calls, and I'm not going to get into graphic details at all, except to give a little background on how these things can develop in a first responder. But one of my first responses as a firefighter was on a car accident that ended up with 5 fatalities, 3 of which were children. And at that time, I was 16. I ended up driving an ambulance into the hospital that had the mother of one of the children who was killed, and that had a tremendous impact on me. At 16, I was not prepared to deal with that at all. I also, very early on, when I turned 18, my very first 911 call on an ambulance was on a family member who had been shot and who subsequently died. Again, very traumatic exposure for me at 18 years old, was not equipped to deal with that. And as a result, I suffered a lot of traumatic experiences as a result of the job and as a result of those particular experiences. And I started self-medicating with alcohol to try and get through that. I love the fire service. I knew I wanted to be a firefighter, but very early on, had sustained some pretty serious psychological damage as a result. And it wasn't the type of thing that we really ever talked about. It wasn't permissible really to talk about behavioral health because of the stigma and the fear of looking weak. So I continued on through my career. I became a professional firefighter, a career firefighter. Things with my drinking got worse and worse and worse. Finally, 8 years ago, 8.5 years ago now, I was called for a random drug and alcohol screen, and ended up, I had a positive breath test when I came in for my shift one morning. I didn't expect it. I never drank on duty, but I really drank hard on my days off work. So I was suspended. Fortunately, in Indianapolis, we have a very good employee assistance program. I was able to go through that, and I got sober a little over 8 years ago. And that's how I got involved in behavioral health and peer support. I knew that I wasn't the only firefighter in Indianapolis that had those issues. So I wanted to figure out a way to assist with that. And that's kind of where the positive things really start. It opened up a whole new life for me, helping out other firefighters, EMTs, paramedics, and even some law enforcement through our peer support program. I took a teaching position with the International Association of Firefighters, where I go out and teach a 2-day peer support training to help fire departments set up their own peer support programs. I'm a resiliency instructor for the International Association of Firefighters. As Blake mentioned, I was able to get my certification for peer recovery coach and certified recovery specialist, and then most recently completed yoga instructor school. So a lot of things have happened, and that's the beauty of recovery, is that people get better, they get better all the time, and that there is hope, and that when you do recover, a whole new world opens up to you. So I know it's kind of a lengthy intro, but I wanted to share my story as part of this symposium, just to kind of show that I know where all this comes from and that recovery is possible. Here are our goals as we go through this session. First, we're going to examine alcohol use disorder, post-traumatic stress disorder, and sleep deprivation, and how those topics all kind of tie together in public safety, and in particular the fire service, how they interact and can cause problems for today's firefighters. We'll take a look at suicide. It is obviously not recovery linked directly, but I do think that there is a tie-in because we see substance use in a lot of suicides. The issues that we see leading up to suicide, maybe the PTSD, the anxiety, the depression, substance use, do tie in that regard. So we will talk some about firefighter suicide, what we do know and what we don't know. We'll take a look at our peer support program in Indianapolis and the 5 ways that we engage with firefighters. We've had great success. We've kind of revolutionized first responder behavioral health here in Indianapolis through the program that we have with Indianapolis Fire. And then finally, for any clinicians who may be in attendance, we're going to look at 7 questions that our program asks clinicians, things that we need answers to before we refer a firefighter to a clinician. So that can be useful for people who may be interested in working with first responders, kind of what we expect or what you can anticipate we're going to ask about. So the first thing to look at is we're well aware, at least I'm well aware, that firefighters have a hard time seeking treatment. Even when they know there's a problem, they still won't seek it out. I don't think that's unique to the fire service at all. That's something we see across populations. And why do we see that? Why don't firefighters want to get treatment? The answer, just like, again, across all populations, is there's a real fear of stigma. This study was completed by the Warriors Research Institute by Dr. Susie Gulliver. She's a professor at Texas A&M with their School of Medicine. And she works with first responders and military personnel on behavioral health topics. And she surveyed about 2,000 firefighters and asked them, you know, would you get help? And if not, why not? And 92% responded that the reason they would not reach out for help is they would be fearful of stigma. The fire service is a career in which once you receive a label, for the next 20 years, you may not be able to shake it. So I wish I could say that that fear of stigma wasn't legitimate, but it's very real and it's very legitimate. Firefighters have a reason to be afraid of being labeled because that may stick with them the rest of their career. Now, the issues with getting help aren't limited strictly to stigma. A couple of other issues we run into are firefighters may not know what services are available. They may not know that they have an employee assistance program. They may not know what providers are available outside of their EAP to give them help. And even if they do know that we have an employee assistance program, they may not know how to access it. They may not know the phone number or the procedure. Can I call on my own, or do I have to go through somebody within the fire department? And they're very reluctant to reach out and have those questions answered, because in order to find that out, they have to expose themselves that they need help. And as a result, then the fear of stigma kicks back in. So it all really does tie back to that stigma piece. And there are some practical issues too. Just like any other profession, what kind of sick policy does my fire department have? We're fortunate in Indianapolis, we have a great sick policy. Other departments, you can only take what PTO time you've accrued. And if you have to go away for 60 days to get treatment, you may not have the sick time available to do that. And then there's also the issue of costs. We have high deductible insurance in Indianapolis. That can be a real hardship for people to come up with that upfront money to go get treatment. If you're going to be $5,000 out of pocket before your insurance kicks in, that can be a real barrier. So there are a lot of issues at work that keep our people from reaching out for help, but that kind of lays the groundwork for it. Kind of focusing in on our first goal of looking at alcohol use disorder and firefighters, this is, from my perspective, the biggest issue facing first responders, not just the fire service, but dispatchers, police, EMS, corrections, whoever you consider the boots on the ground people. Alcohol use disorder, I think, is our biggest obstacle. This was from a study done looking at first responders and alcohol use disorder. And the study revealed that among the people surveyed, half of the males and about 40% of the female firefighters admitted to binge drinking in the prior 1 month period. If you compare that to the general population during that same period in which that survey was conducted, the general population was about 15%. So by comparison, we can see that there is, just looking only at binge drinking, that there's a lot more binge drinking going on, at least within those respondents, than there is in the general public. And I was not surprised to see that that's how those statistics came down. That's actually what I would expect, given what I've seen. This is a tremendous issue. You really don't go to anything in the fire service where there's not alcohol being served. Parades, get-togethers, union activities, you name it, and there's going to be alcohol there, and there's going to be a lot of it. That's how the fire service socializes. That's part of our tradition, and there's a lot of pride taken in how much we can drink and how hard we can go at it. So I wasn't surprised to see that our numbers were that much higher. This is actually from an article that I wrote using some SAMHSA data, that when we look at alcohol use disorder among the fire service and the general population, there is a pretty significant difference between firefighter alcohol use disorder and civilian, to the tune of about a 5 times difference, or you're 500% more likely to develop alcohol use disorder as a firefighter than a member of the general public. So again, a major discrepancy we see. This stat goes back to the first stat, the same article, where we saw that half of males and 40% of female firefighters had engaged in binge drinking. They also found that 35% of those respondents noted that a member of their unit had either missed a call or missed a shift due to excessive alcohol use. So over a third of those respondents said, yeah, a member of my crew has missed a call or has had to call in sick to work because of alcohol consumption. Now, the real scary part of all this is the follow-up question to that was, do you think that alcohol use is a problem within your agency? And only 25% said yes. And that's really what's scary to me, that we can see such a discrepancy between alcohol consumption and alcohol use disorder in the fire service, yet the people that are surveyed who see these same problems don't perceive that it's an issue within their department. And until we can really overcome that barrier, I don't think, we're really going to ever get rid of this issue within the fire service. But that, again, is part of our tradition. But looking at the discrepancy in the numbers, that really is cause for concern for me as somebody who works within this world with first responders. Now, something that certainly plays a role in this is post-traumatic stress disorder. We hear a lot about that in the media. It's certainly something that not just within the fire service, but I think nationwide we're talking more about traumatic exposure and what that can do to people. Generally for us, we find, this is a cumulative issue. I think sometimes within the general population, you can be exposed to that one really horrific incident or event, and people can become symptomatic for PTSD and start to have problems. What we notice is overall, we're really pretty resilient, but there's a cumulative effect to this where you're exposed to really horrible call after horrible call, and those things start to build up. And for a number of reasons, some of which we'll discuss in coming slides, we don't really have a chance to process that trauma appropriately. So it builds up and builds up. It's processed and filed away in the wrong areas of the brain, so to speak. And eventually our bucket runs over, or our cup runs over. We can't contain that trauma anymore, and then we start to become symptomatic for PTSD. So for us in public safety, there's definitely a cumulative element to this. If we look at just some quick stats as far as PTSD in North America, in the civilian population between the US and Canada, there's about 8.5% of the population will have diagnosable PTSD at some point in their lives. Military veterans, we look at 11 to 20%. The fire service and also law enforcement are at least 20%. And when we look at EMS, they're at least 30%. So they're the highest of all. So the question is why? Why do we see such a difference between veterans and the fire service, law enforcement, and EMS when it comes to PTSD? And I think there are a number of things at play here. One, a fair number of the people who go into public safety are military veterans themselves. So we have some folks who have military service who are coming to the table, so to speak, with their cup partially full. They have traumatic experiences that haven't been appropriately dealt with. So when they get hired by us, they already have some of that baggage that they're bringing with them. So I think that plays a role. If we look at things like adverse childhood experiences, we know that people with high ACE scores have a tendency to seek out employment in professions where they can protect other people, be decision makers, things like that. So we know that people are coming to public safety jobs who have high ACE scores and have a lot of childhood trauma, perhaps, that has never been appropriately dealt with. So I think there's two issues there, that we have veterans coming in, we have people with higher than normal ACE scores who are drawn to these professions. And then the other issue is that cumulative effect. Just the sheer volume of things that we see over a 20 to 30-year career leaves its mark. As an example, if we look at an Indianapolis fire engine, and a very slow Indianapolis fire engine will make about 1,000 calls a year. We have some apparatus that make over 5,000 calls a year. But just taking a 1,000 call a year fire engine, a firefighter will be on duty a third of those days. So we can safely assume that firefighter, we'll just say, goes on 300 emergency calls a year. And let's also assume that firefighter works a 20-year career. That's usually the minimum we work for our pension, but some firefighters work well beyond that to 30 plus years. But we'll just assume a 20-year career at 300 calls a year. So that means that firefighter will go on 6,000 responses over the course of their career. Let's assume that 90% of those calls are nothing, not anything that's going to affect that firefighter. And that's a pretty low estimate to say that only 10% of the calls were significant. But for our purposes, let's just say that only 10% of the calls that firefighter goes on are traumatically significant. That's still 600 significantly traumatic events that firefighter is responding to over the course of a career. And that's a lot to process. So it's almost surprising that our numbers aren't higher than they are. But I think it speaks volumes about how resilient firefighters are. And a big part of that is the social supports that we have within our fire stations and within our crews, that we're able to go to these calls and talk about them afterwards, immediately afterwards with our crew members. We can sit around the kitchen table and talk about them. That all plays to our benefit, I think, as far as resilience goes. But that still really lays out the groundwork, just the tremendous volume of traumatic incidents that firefighters are exposed to over the course of a career. Another factor that plays into this is sleep deprivation. The top line here lists out some of the more common schedules that firefighters work. In Indianapolis, we work a 24/48 schedule. So we work for 24 hours, and then we're off for the next 48 hours. Out west, particularly California, the 48-96 is the most common schedule. So you actually leave for work and you're on duty for 48 straight hours, and then when you leave, you're off for 96 hours. And then a third very common schedule is the 24-24 times 3. So with that, you work 24 hours, you're off 24, on 24, off 24, on 24, and then you're off for 96 hours. They all have their benefits, they all have their drawbacks, but those are all very common, and the one common thread between all of them is we're at least working for 24 hours straight. And that's very important when you look at sleep deprivation and how many times that we get woke up during the middle of the night and we have trouble getting a solid 7 hours of sleep. I don't remember ever getting 7 straight hours of sleep when I was out working in the firehouses. And that's years and years and years of that. The sleep deprivation is tied to impairment of extinction recall. That's more of a complicated subject, but to very loosely describe that, it's basically the way that our body and our mind figures out that we've lived through this incident and now we're safe. But when you don't sleep appropriately, when you're sleep deprived, your mind doesn't reach those same conclusions as far as your safety and that incident is over. We see there also that people who are able to sleep after a traumatic event fare better than those who aren't. In the firehouse, you'll go on a traumatic event and come back, and within minutes, sometimes you're redispatched to something else. So a lot of times we don't get the chance to lay down and go to sleep so that our brains can process what we've lived through, and that leads to problems like PTSD. And you see the statistic there, almost 40% of firefighters suffer from a sleep disorder. That's astounding. I don't know what the general population numbers are, but 40% of firefighters with a sleep disorder is undoubtedly markedly different than the civilian population. The article Addicted to Awake that I have cited here is phenomenal. If you're interested in learning about sleep deprivation and first responders, it's one of the best articles I've ever read. And this really has far-reaching impact. When we look at causes of death and disease among firefighters, and again, this is based on that less than 7 consecutive hours of sleep. Some of the things that we see happening are things like heart disease, which year in and year out is one of the biggest killers of firefighters. Things like metabolic syndrome, diabetes, we get glucose tolerance issues, all can be linked back to not getting enough sleep. And then we also see the behavioral health side of things, from anxiety, depression, and alcohol use. And again, that is the alcohol use side of things has certainly played itself out within the fire service. So how does this all kind of tie back into PTSD and its relevance there? To look at the sleep cycle a little bit, I mentioned, when you're on duty, you get woke up a lot. Even if I can remember times where I didn't go out on an emergency call throughout the night, but I still didn't sleep through the night. In the fire service, most firehouses are designed, the sleeping area is a dormitory. So for example, one of my last assignments, I worked with 10 firefighters and we all slept in one open room. So all night long, people would be getting up to go use the bathroom. Somebody would be snoring, somebody talking in their sleep, somebody's phone buzzes or dings with a text. All of those things wake you up. We had an engine and a ladder at my assignment. I was on the ladder, but every time the engine got a run, it woke us up as well. And then when we got a run, it woke the engine up. So you never sleep through the night in the firehouse. So what does that mean practically? How does this tie into PTSD? When we look at the sleep cycle, the way it works, and I think they run about 90 minutes to go through a full cycle, and we have several cycles through the night as we sleep. And those cycles begin with a lot of deep sleep, and then the last part will be REM sleep. And then the next sleep cycle, that deep sleep decreases a little bit and the REM sleep increases. And then as you go through the night, that actually inverts, so that by the time you're in your closing sleep cycles, you have just a little bit of deep sleep and a whole bunch of REM sleep. Well, our bodies process trauma, our minds process trauma during REM sleep. When you're getting woke up several times a night, your sleep cycle resets. So the issue becomes that first responders who have to wake up several times are losing out on that REM sleep that they would be getting towards the end of the night as their sleep cycles begin to invert and give them the REM sleep to process trauma. So as a result, we never process it. And then that builds up, and that's why we see that cumulative effect. And then at the end of the day, that's when we become symptomatic for things like PTSD. And then we also try and self-medicate the anxiety and the hypervigilance and the issues that go along with PTSD with alcohol. So we see it all tied back, how it all kind of works together with the sleep deprivation, alcohol use disorder, PTSD, post-traumatic stress. It's one big ball that we have to unravel in order to make sure the first responders are getting the help that they need. Unfortunately, we know that things of this nature can sometimes result in suicide. Suicide's a complicated subject. I'm not trying to say that it all boils down to alcohol use disorder. It all boils down to PTSD. I know it's not anywhere near that simple. But are these things factors that can lead to suicide? And I say absolutely. And this is something that first responder suicide that is getting a lot more media attention, particularly in the law enforcement community. It seems like we're seeing a lot more suicide among first responders than we have in years past. And that's kind of what we're going to take a look at here is how much do we know and how much don't we know about this? Are suicides up? Yes, I think they are, absolutely. As a proportion of people working in this field, are they up? That's, up for debate. When we look at some of the figures, we have to really ask, are they reliable? When we're doing comparisons, how reliable are the comparisons that we're doing between first responders and the general public? And this was brought to light with a really big law enforcement survey that was done several years back, where the researchers compared suicide among police officers to the general population. And when they did that, they found that law enforcement officers were considerably more likely to die by suicide than a member of the general population. However, they were savvy enough to recognize that the average police department, the average law enforcement officer, doesn't look like the general population. So they adjusted for some demographic differences so that the sample group more accurately reflected what we would expect to see in a law enforcement agency. And when they did that, law enforcement suicide was actually considerably lower than the general population, at least among a comparative group. So that kind of called into question whether or not law enforcement suicide was abnormally high when compared to other people that they should appropriately be compared to. So, okay, that's law enforcement. That's one study. Instructive, but certainly not conclusive. So what do we see on the fire side? The Chicago Fire, excuse me, the Chicago Fire Department several years back had 7 suicides in 18 months. And at the time, Dan DeGrice was with the Chicago Fire Department. He actually just recently retired as a battalion chief. But Chief DeGrice was the coordinator for the Chicago Fire Department Employee Assistance Program at that time. And he wanted to investigate what was going on and how did Chicago compare to the other populations as far as suicide and firefighters dying by suicide. So he looked at 20 years worth of data for Chicago firefighter deaths, how many of those were suicides, and these were confirmed that we know they were suicides. They were ruled suicide. He took all that data, took it over to Northwestern, and had, the statisticians at Northwestern crunch those numbers to determine what the suicide rate was for Chicago firefighters during that time period. And then they compared that to the population. And they found the same thing as the law enforcement survey, that when compared to the general population, Chicago firefighters were considerably more likely to die by suicide. They then did the adjustments for demographics, and they found that Chicago firefighters were still slightly more likely to die by suicide than a comparable group. But it's worth noting that when they adjusted for demographics, they did not adjust for age in that. So had they adjusted for age, that probably would put the Chicago firefighter suicide rate below the comparable group, but we don't know that for sure. But we do know without a doubt that it brought that rate way down when compared to a group that looked more like the Chicago Fire Department. Another study that was done with the Philadelphia Fire Department, and without going through all of it, they reached the same conclusions. This study was done by Joyner Laboratories. Dr. Thomas Joyner is one of the leading suicidologists in the United States, and he runs Joyner Laboratory, which is part of Florida State University. And this study was headed up by a gentleman named Ian Stanley. And Ian and I have presented a couple of times, and I actually reached out to Ian to find out, what can we glean from these numbers? We can see that, at least as far as the Philadelphia Fire Department and the Chicago Fire Department, that when adjusted for demographics, we don't see a huge difference or firefighters are not more likely to die by suicide than other groups. And he said that, that is true. We see that at least with these two departments, but I do want to caution that these numbers aren't the be all end all, right? We're looking at two very large fire departments in very large metro areas. Maybe we see lower than that expected suicide rates in those agencies because they have more resources. Or maybe we see them because I can go 2 neighborhoods over and see a clinician and I don't have to worry about anybody I know seeing my car there. So there are a number of things that may account for why we see lower suicide rates in these agencies. But I do think it calls into question the notion that firefighters and police officers and other public servants are dying at rates that are way out of sync with comparable groups. But what are we seeing then? And again, we're going to get through some quick stats here, but I do think this is incredibly relevant to what we're seeing. When we look at suicide in general, what this chart looks at is sex and age. And we see that males overwhelmingly die by suicide more often than females, and older males die by suicide more often than younger males. So working age males are at higher risk for suicide. And then when we consider race, the two groups who die by suicide most often are American Indian and Alaska Natives, and then the other group is whites. So the U.S. Bureau of Labor Statistics tells us that about 96% of the fire service is male and 82% of the fire service is white, and we're all working age. So I think that we can see the correlation between suicide and the fire service simply by virtue of the fact that the suicide is overwhelmingly made up of middle-aged white males. So regardless of what we do for a living, our group would be more likely to die by suicide than other groups. And I really think that that's what accounts for the numbers we see in firefighter suicide, much more so than any link to firefighting itself. Having said that, what are some statistics that we can turn to make the argument that we need more behavioral health programming in the fire service? This is a chart that compares line of duty death with firefighter suicide. And what we can see year in and year out is that firefighter suicide far outpaces firefighter line of duty deaths. And that's certainly not something unique to the fire service. I think we probably see that in most jobs, that more people will die by suicide than actually die at work. But where we can make the argument for the fire service is, look, when we consider how much money is put into preventing line of duty deaths with better gear, better training, all kinds of things that we invest in to prevent line of duty deaths. But yet we see nowhere near that type of investment in suicide prevention and behavioral health programming. And why is that? And that's the question we have to ask. When we're seeing sometimes twice as many firefighters die by suicide as die in the line of duty, it's a question worth asking, why aren't we investing in prevention efforts for our firefighters on the behavioral health side? To some extent, I think that municipalities are able to avoid answering the question because line of duty deaths by their very nature are happening on the fire ground. They're happening within fire department vehicles and crashes. They're happening at the fire stations. Suicide, on the other hand, generally doesn't occur at the fire station. It occurs off duty. And so municipalities can kind of wash their hands a little bit and say it didn't happen here, so it's not our problem. But we know that a lot of the issues that lead up to that suicide may very well be job related. And that's where we have to hold our administrations and talk to them about the realities of, we need to start investing in this type of programming to prevent the suicides, because we know that a lot of them are job related. Indianapolis is no different. In the last 18 years, we've had 5 suicides and 1 line of duty death. That's not uncommon among fire departments across the United States. For me, the stat that really brought it home was that for the last 20 years, suicide is the leading cause of death for active duty Indianapolis firefighters. I think a lot of people would expect that to be heart attacks or cancer or strokes, but it's not, it's suicide. So there is something to be said that while I may not believe that there is a big discrepancy between suicide among firefighters and suicide among the general population, the fact that any firefighters are dying by suicide means we need to be doing something about it. So what we've done in Indianapolis, particularly under the guidance of Chief Ernie Malone, our current chief, is we have really invested in behavioral health programming. In fact, we just opened up a health and wellness center here in Indianapolis for the fire department, and that building houses our fitness program and our behavioral health program, so that we are now treating behavioral health and physical health on an equal plane in the Indianapolis Fire Department. And if you have an issue with either one, you come to the Health and Wellness Center, and we have peer fitness people and we have peer support people here that will help direct our firefighters, talk to them about what they're looking for and get them the assistance they need. And that's really revolutionary. I don't know really of many other fire departments in the United States who are set up and equipped as well as we are to handle these types of issues. And the starting point for us was through our peer support program. And what is peer support? It's very similar to other peer supports that we see in behavioral health, except that we're just firefighters, active duty and retired firefighters who serve as that bridge for firefighters who are having stress in their lives. We figure out, you know, what can we do to help, and then we serve as that bridge to get them the help that they need. We're not clinicians, we're not counselors, we're not therapists, we're just other firefighters. Where we do differ a little bit from other peer supports is, like, as an addiction peer recovery coach or recovery specialist, that type of thing, they're generally companies are going to look for people who have lived experience with a substance use disorder to help other people with substance use disorders, or people with mental health concerns to help other people with mental health problems. And that's the relevant lived experience. When it comes to fire service peer support, we're not as concerned whether or not our firefighters who are on our peer team have had an alcohol problem or have suffered from depression or anything like that. The key for us is that they have worked as a firefighter. That is the relevant lived experience. Fire departments, firefighters, police officers, EMS workers are very closed societies. We really don't trust people outside of our groups. We especially don't trust people outside of our groups when it comes to things like mental health and addiction. So in order for us to open up, I have to know that I can trust that other person, and the person that I trust most in this world is another firefighter. And that is across the United States and Canada, that is the fact, that nobody trusts a firefighter the way they trust another firefighter. So that's where we draw our peers from, regardless of any other lived experience. That's what's most relevant to our people. So our role, as I said, you know, we have things like employee assistance programs, chaplain programs, legal aid, financial assistance, all these different areas where firefighters can seek out help, but they may not know how to access those resources, or they may not know that those resources even exist. And that's where our peers come in. They serve as that link in the chain, that bridge that can connect the firefighter in need of assistance with the help that's out there. And that's all they are. And that's all we tell our peers. Hey, you are just the link. You are the bridge to get the people the help that they want. We are resource managers. And here in Indianapolis, we engage in 5 different ways. We do routine visits, requested visits, potentially traumatic event callouts. We engage in education, and we also track sick and injured lists. And I'll go through each of those individually here to kind of give a little background on how peer support in the fire service works. And the model that we use here in Indianapolis was one of the first peer support models developed in the fire service. So when the International Association of Firefighters was developing its peer support training, they actually called upon our clinical director, Dr. Robert Smith, to help them out with how do we build a peer support program. And it was at least partially based upon the Indianapolis Fire Department program when the IAFF developed its training. So we really were the leading edge among American fire departments as to how do we do peer support. So the first way we do it is through routine visits. And this was really kind of a remarkable thing that we did here. It doesn't seem remarkable probably to most people who think about it, but in the fire service, traditionally what we did was we would wait for something really horrific to happen, and then we would ask people if they needed help. Like we would completely 100% reactive. We didn't front load our programming at all. We didn't let people know we were out there. We just waited for that bad event to happen, and then we tried to play catch up. And that's kind of been the standard in all public safety. That's how it's done. You wait for the really bad call, and then you send people out to try and help. What we realized is that if we want to develop resilience in our people, we need to be more proactive. There is a place to be reactive, and we'll discuss that, but overall, we need to be proactive. That's how we develop the resilience so that our people can bend and not break whenever they're faced with that horrific situation. We also recognize that the difficulties we face in the fire service aren't limited strictly to those really bad calls. You know, firefighters have spouses who get cancer. Firefighters get cancer. Firefighters run into financial issues. They lose part-time work. It's COVID. Maybe their spouse has lost their job. So now they're in financial trouble. Those are all things that we can help front load by developing resources, you know, initially before things start going wrong, and educating our people about the resources that are out there. So what we would do in a routine visit is we would send 1 or 2 peers out to a firehouse when there's nothing wrong. They just make a phone call and say, hey, you know, this is Brandon from peer support. I'd like to swing by the station and just talk to your crew real quick about what we're doing in peer support. And our goal there is just to try to normalize this discussion. We like to sit down at the kitchen table, which is the hub of all fire service life, is the kitchen table. Sit down there with a cup of coffee and the rest of the crew and talk about depression. Talk about PTSD and anxiety. Talk about substance use disorders and how firefighters are known to drink too much. And get that discussion out there in the open, when there's nothing wrong. Do some education, but our real goal there is to normalize this discussion so that people get used to hearing about it. And also, we want to validate the experiences of other firefighters. We know that people sitting at those tables have experienced the things that we're going to be talking about. So this gives us a chance to validate what they've gone through, which again makes it more likely that when they need it, they're going to reach out for help. Now this, you know, in a career fire department is usually pretty easy to do because I know where everyone's going to be on their shift. This can be more of a challenge in a volunteer setting, volunteer fire department, where people show up whenever they're called. But you can work around that with having these types of meetings at monthly trainings or having special trainings where peer support comes and talks to them. So while it's a little more difficult, it shouldn't be a factor that keeps you from starting peer support just because of that. There are ways around it. But the real key is that this is a movement towards being proactive rather than reactive. The next thing we do is requested visits. This is on the reactive side of things. So an officer within a fire department unit or another firefighter will notice a problem in a colleague, and they will reach out to us and request that we come and help out. So while it is still reactive, something has gone wrong or is going wrong before they call, our goal is that if we've done our job with routine visits, people are going to call sooner and sooner in the process to request us. So we're going to be in the very early stages of the problem, which is better off for everyone. So that's how those routine visits really tie in to develop the trust in our program and to reduce the stigma so that people will reach out to us earlier and earlier. And this can take years. It's taken years to develop that trust here in Indianapolis, but we're really seeing it pay off now. I routinely will have officers call me up and ask for advice or ask us to get involved. I have battalion chiefs who call and say, hey, can you reach out to this person? I'm not sure what's going on. I don't need to know. I don't want to know, but if you could give them a call and see if there's something you can help out with, I would appreciate it. And that's great. That's what we're shooting for. And that's what we can do with requested visits is they know they can trust us, and we can send our people out discreetly and privately to help out other firefighters in confidence. There's also a lot of flexibility with this. You really have to make your team available 24 hours a day, which is what we've done. 24 hours a day, somebody from our team will be available to talk and hopefully also meet with someone if they need it. Not surprisingly, a firefighter doesn't want to call up headquarters to talk to someone in peer support to talk to them about their heroin problem while they're on duty. They want to do that off duty where they feel safe and where their repercussions aren't going to be there to talk to somebody. We understand that, and that's why we have that flexibility so that we can meet the firefighters where they are, and so that they can be assured of their safety and their privacy, and that they can reach out to us, and that we're not going to look at discipline or anything like that. Our goal is to get them better, and we give them the flexibility to set the terms on, hey, this is how I want to meet, this is when I want to meet, and we can work with that. And that's the real beauty of peer support in the fire service. I mentioned that we do still do reactive things. Traumatic event callouts are basically how we do that. This is traditionally what has been associated with behavioral health in the fire service. We have that really bad call, and then we kind of scramble to figure out who needs help and how do we get them the help they need. There's really no other way to do this until you have the bad call or whatever it may be, to reach out and get people into the help they need. So you kind of have to wait for that thing to happen before we can move on it. But what we have done that has really revolutionized this is the way in which we engage in these call outs. You can see listed here that the types of things that we would expect to evoke a strong emotional response among our people. And what we used to do after those really bad calls was we would have everyone who was on that call gather as a group in a central location, and then we would engage in a debriefing or something of that nature to talk to everyone as a group about that call. That works in some cultures, that works in some agencies. That did not work in Indianapolis. Our crews did not want to be pulled out of their firehouse to put on a blue shirt and a badge to go meet with a bunch of other firefighters from a call to talk about it. It just didn't work for our people. So what we ended up doing was, after those bad calls, when we hear about them, we just call and check in with the officer and ask them, hey, how's your crew doing? You know, we find out and make sure everybody's functioning appropriately. If we need to pull somebody off the line, we can do that. Again, it's not punitive. We just make sure that everybody's safe. We let the officer then know that, hey, next shift, we're going to send a couple of peers out to your fire station just to drop off some information, talk to your crew about resilience, talk to them about the resources that are available, and then we'll be out of your hair. And we've taken a process of gathering everybody from a call into a central location that took anywhere from 1 to 2 hours into a situation where we can meet firefighters in their station for 15 to 20 minutes. We're in, we're out. They don't have to do anything. We meet them where they're most comfortable. And what we found is, you know, an hour or two after we leave, we start getting calls from firefighters who want to reach out and talk to somebody and maybe access some resources that they would have never done had they had to meet as a large group. So this has really been something that the fire service has caught on to and has really shifted the paradigm in how we address behavioral health issues after really bad calls. Again, depending on department or agency structure, like a volunteer fire department, you may have to meet as a group. You may have to meet as everyone who was on that call. But even then, the change in approach that we've made is we really don't talk about the incident itself. We address why we're there and say, you know, we're here because we had that bus crash. We recognize that. We just want to make sure that you all have the tools that you need. And then we go into resilience and we talk to them about our resources. But that has really shifted the paradigm in people's willingness to accept help from peer support programs, at least in Indianapolis. We also use as many educational opportunities as we can. We get in and we talk to our recruits twice. We talk to them at the beginning of recruit school and we talk to them again at the end of recruit school. The best way that we have found to again, shift that paradigm so that people are willing to reach out to help is make it part of the normal conversation. Make behavioral health part of your responsibility from the day that you're hired, just like your physical health, just like we're expected to maintain certain body weight and physical standards. We need to be aware that we have to maintain certain psychological standards as well. And we do that by instilling the trust in our program and the knowledge about what resources are available and what to be looking for in themselves and in other firefighters by doing that in recruit school. And we've seen a big shift there. And part of that, I'm sure, is also generationally. Younger generations are more open to discussing behavioral health, so that's worked to our benefit as well. Anytime we promote officers, we have an officer candidate school, and again, our program gets in front of those officers and lets them know, hey, just like if you had an injured firefighter, physically injured, you would want to get them in and get them assessed and get them help. Same thing with behavioral health issues. If you suspect that a firefighter is having these types of problems, it can be a safety issue. And as an officer, your crew's safety is your responsibility. So we put that onus on the officers to reach out to us and let's get your people help. And again, we're seeing that pay off just by addressing it year after year after year and making it normal to discuss this. We're seeing it pay off now. We also do annual incumbent training where at some point during the year, we talk to all of our personnel about behavioral health. Again, normalizing and validating. We also know that ignorance is what drives stigma. When you truly understand behavioral health and what it is and how it works, there's nothing stigmatizing about it. It's just like any other physical issues. They arise and we can help treat them and we can get people assistance. By educating our people about what these behavioral health issues are and what treatments are available, we can help destroy that ignorance and thereby also destroy the stigma. And that's our ultimate goal. The final thing that we started here in Indianapolis was tracking our sick and injured lists. So what we do here is if a firefighter is off for 2 straight weeks, a member of our peer team will reach out to them and check in with them. Doesn't matter why they're off. Our peers most of the time don't even know. I just will say, hey, firefighter X has been off duty for 2 weeks. I need you just to reach out and do a check-in. And that's exactly what they do. They let them know, hey, I'm Brandon from the peer team. Saw you've been off for a couple of weeks. Just want to check in, see how you're doing, see if you need anything. You're able to get groceries. Is your grass getting cut? Is there anything we can help you out with? Again, very proactive. No indication at all that something is wrong. But we know that at that 2-week mark, firefighters will really start. There's a higher risk that they're going to self-medicate. Also, if they're depressed, that 2-week mark for somebody who may be suffering from depression is very important for diagnostic reasons. So that's kind of why we picked that 2-week delineation to reach out and ask people how they're doing. But that has meant more to our people probably than anything else we've done. Just the fact that, hey, I've been off work and somebody actually took the time to think of me and reach out and check in to see how I'm doing. That's unheard of just 5 years ago. There's no way that would have happened. So it means a lot to our people who have been separated from their second family. And that's, you have to remember firefighters spend 24 hours to 48 hours together straight. So at least 1/3 of our life is spent with these people, eating together, sleeping together, working together, risking our lives together. It is an incredibly strong bond. And once we're separated from that, it can cause a lot of problems for our people. So this has been an incredibly valuable tool that we use here in Indianapolis. So that kind of sums up how we do peer support here. I'll move on the last part, 7 qualities that we look for in clinicians or 7 questions that we ask clinicians. And the first thing that we always ask is, have you worked with firefighters or first responders in the past? We are a unique group. We are a difficult group. A lot of firefighters and first responders take a tremendous amount of pride in being difficult. That's kind of the reality. And we want to know if you've worked with us before. We vet all of our resources. In fact, I am leaving here fairly soon to fly out to California to spend a day at a treatment facility to actually undergo a day of what they do at that facility, because I want to experience it before I ever refer one of our people out to that facility. So it is really important that you understand who we are, what our culture is. The IAFF, our international union, has a course that clinicians can take to learn about our culture, because it is, if you don't know us, you'd sit down around us and probably think that we're all pathological on some level, just the way we talk to one another. So understanding that culture and why we are the way we are is really important, and that's something that we always check on. This, and I'll preface this one by saying sometimes our expectations can seem unrealistic, and I would admit that that might be true, but this is nevertheless what we as first responders expect. And this isn't unique to the fire service. This goes for law enforcement and EMS as well. But we want to know how quickly you make your initial assessment. How quickly do you complete that? If it's going to take more than 2 visits for us to get to work, our people will stop coming. We have just found that firefighters have to have some type of assessment done within 2 visits, or else they think that you're just dragging them along, trying to get money. You're not really trying to help me out. You just want me to keep coming back. We are a very cynical group, and we will immediately think that you're trying to play a game with us if we don't get a diagnosis very quickly, or at least some assessment done with some results early on. So we like to say 2 visits, we need an assessment complete. Another question is, are you willing to participate in experiential training or other ways to understand the fire service? There's a program, Fire Ops 101, which is an 8-hour training that generally government officials go through, but it can be open to clinicians as well. But something as simple as doing a ride out, signing a waiver and riding a fire truck for 8 hours can teach you a lot about what we do and the types of calls we make. Coming to the firehouse and just eating supper with us will be an eye-opening experience for anyone who doesn't understand the fire service or who wants to learn more about it. Like I said, the kitchen table is the central nervous system of the fire service. Actually sitting down and breaking bread with us goes a long way towards getting to know us and towards us starting to trust you, especially if after dinner you help clean up, help do dishes, help mop, that type of thing, become one of the crew is vital. But we want to make sure that if you're open to that, we get you in and let you actually see firsthand how we live. The next is, what evidence-based practices do you use for things like PTSD and co-occurring substance use disorders? Standardized time-limited interventions work best with us. We like structure. We like to know what's coming next. We like to know how this process is going to work. So those type of interventions are very good. And any intervention you can do that gives us homework is very valuable. We are fixers by our very nature. It's what we do. And I want to start fixing my own problem. Let me get involved in my own treatment. Give me homework. Don't just let me sit and wonder what's going to happen next week when I show up. Give me something to do. That goes a long way. And that's something that we check on is, what type of treatment approach do you have? Also, do you work with a prescriber? We really have to coordinate care. There are certain drugs and medication that we can take and some things that we can't. And still report to duty. If you have a prescriber who is also willing to become familiar with the fire service, that can be really valuable because we can streamline that process, get our people on medications that will still allow them to come to work ideally and start functioning again. So do you work with a prescriber is another question. This one is a really big ask, but do you offer appointments within 24 hours or do you have access to an on-call clinician? We recognize that this is a tough one, but in a firefighter's mind, when I'm on duty 24 hours a day at 2 in the morning, when your world is crashing down around you, you call me, I get out of bed, I show up, and I help take care of whatever crisis is destroying your life right then. That's what I do. And I'll risk my life and potentially die to get that job done. So we expect that when I need help, I make that call, I'm going to get help quickly because that's exactly what I would do for you if you called me. And that may be naive, but that is how a firefighter is going to look at that relationship. In some communities, an emergency department may be the only answer after hours, and I can tell you that almost without exception, firefighters are not going to use that. We know the people who work in the emergency departments, and because of stigma, because we're embarrassed, because we'll feel shame, we won't go to an emergency department to get help. So developing that 24-hour type relationship, or what can we do after hours, is vitally important. And then finally, do you have facilities that you refer to regularly so that can we set up a system where our people don't have to go through the lobby? Can we use a side door? Again, we're somewhat public figures. We like to maintain our anonymity. This is especially true for law enforcement if they need to go to rehab, to walk through a lobby with people who maybe they've arrested in the past on drug charges and now they're showing up themselves to go into rehab can be problematic. It's the same for firefighters and EMS. So if we can streamline that access to inpatient care, incredibly valuable. I have just a couple more slides here. I always like to refer people to a couple of books if they want to learn more about working with first responders. Bulletproof Spirit is a great resource. It talks about self-care, but there's also some really good stories about law enforcement and firefighting. I encourage anyone to read that book. Another is Emotional Survival for Law Enforcement. It really gets into the biology of what's happening, how hypervigilance arises in first responder communities, how it can be effectively dealt with, how it affects families. And it's actually a very short book. It's 100+ pages, can generally be easily read in a day. If I had to recommend one of the two, I would probably recommend Emotional Survival. And that's relevant whether you're a cop, firefighter, EMS, or somebody who loves them or works with them. I encourage people to check those books out. The final thing here, I wanted to mention Project Echo. There's another Project Echo launching October 6th on first responders. And it's going to deal with a variety of topics, things like stigma, legal issues facing those with substance use disorders, community corrections, drug courts. I will be doing a piece actually for first responders on resiliency and self-care. But if you're at all interested in that, there's a lot of continuing education, not just for clinicians and peers, but also for EMS and law enforcement personnel who need continuing ed hours. You can register for that at oudecho.iu.edu. So if you're interested in that, please check it out. It's a great project. There's my information. Please feel free to call me, email me with any questions. I think we'll have time for questions here as well. But that's my presentation. Thank you everyone for being here, and I'd be happy to entertain any questions we have in the last few minutes here.
Captain Dreiman, thank you for an excellent presentation and for walking us through the uniqueness of firefighters and first responders, especially as the work that we're doing in the recovery community directly impacts them on a day-to-day. Several comments on just an amazing presentation, and thank you so much for the background and details. In addition to that, one specific question: what is the opportunities for mobile integrated response team coordinators to attend
audio-wise? I can't hear any audio. I'm sorry.
Captain Dreiman, are you able to hear us now?
I'm having a lot of trouble hearing any of the questions. It's really broken up.
Okay, give us one moment and we will turn to another audio option.
It's still broken up pretty badly. Looking at my screen here to see if I can.
For all of our attendees, if you will hold tight, we will switch to a phone option for Captain Dreiman. Just one moment. And for those that can hear, just one moment as we transition to another audio option.
Are you able to hear us now?
Yes, I can hear you.
Excellent. Additional questions that have come in regarding the state's investment in mobile integrated response teams, where first responders are providing support and working with peer recovery specialists and peer recovery coaches. Are there recommendations for additional trainings or certifications or other ways to establish additional promotions and marketing to firefighters and other first responders to join the mobile integrated response team program?
I'll be honest, I don't know off the top of my head even a lot about those programs. Traditionally, and this may somewhat go to the root of the question, fire departments aren't normally really involved with those, at least around here. Traditionally, law enforcement and EMS, as well as maybe a social worker or a nurse are involved with those. But for whatever reason, the fire service in this area has not been involved with those. I know in Boston, they have a program where the fire department is involved in that, but it's just not something that we see here. So I am not sure what additional trainings or connections there are out there at least as far as the fire service or other public safety agencies to do that.
I think it speaks very well that you have excellent self-care programming for firefighters, and that essentially could be an extension to those mobile integrated response team
I've lost you again. I'm
coordinators.
sorry, I can't hear you.
Captain Dreiman, are you able to hear us now?
I'm sorry, can you hear me, Sonny? It's really breaking up again. I'm sorry.
No worries. It might be due to bandwidth or connection issues on your end, but the audience is able to hear you very clearly.
Okay.
One additional question, as we look at the firefighters and the International Association of Firefighters, can you share with us some additional initiatives that are coming up in training on self-care and types of harm reduction?
I'm looking, I think the question might have been what initiatives might be coming up within the IAFF and the fire service. If that's the question, I'll answer. I apologize. It broke up. I'm sure it is probably bandwidth on my end, and I apologize for that. There are several programs for firefighters through the IAFF. There's the peer support training. There's an 8-hour online training at IAFF.org. It's open to everybody, and it talks about behavioral health in the fire service. You don't have to be a union member to access that. It's open to everybody who wants to go check it out. And you can just internet search International Association of Firefighters. They have a behavioral health page on the IAFF website, and you can access that training there. If you're not a member, you just log on as a guest and you can take that training. And it really gets into some of the more common issues we see in the fire service with behavioral health. We have a 2-day peer support training. If you've taken that 2-day training, you're then eligible to go through disaster response training. So we will send teams out to help firefighters at hurricanes. We'll send teams out after a firefighter suicide. We'll send firefighters out after a mass shooting. I went to the Pulse nightclub shooting and helped out the Orlando Fire Department after that. We also have a suicide prevention training coming out this year that will be open to peers. And we have a resiliency training that's open to everybody, and that's going live probably within the next month or so. So the International has taken behavioral health to the next level, really, by offering a lot of new programming. They also have the clinician program that you can email behavioralhealth@iaff.org if you're a clinician interested in learning more about that. Again, that's behavioralhealth@iaff.org. Just email them, let them know that you're in this training and are interested in learning more about that, and they will get in touch with you.
Captain Dreiman, thank you so much for your excellent presentation and your insight into firefighter behavioral health and peer support. We certainly appreciate you and all of the amazing first responders that have worked in each of our communities, and we continue to support on self-care and also on a collaboration within the recovery community. At this time, we are going to close the session for Captain Dreiman, and I'd like to welcome back Blake Wood to intro us to our next session. Thanks so much, Captain Dreiman.
Thank you, I appreciate it.
Yes, Sonny. Captain Dreiman, thank you very much for your wonderful presentation and for your continued service to the city of Indianapolis. The information that's been shared today during this session certainly has helped us understand the importance of behavioral health and peer support among our hardworking, wonderful personnel and emergency services. I think that everyone online will agree that this has been another excellent webinar for the INARMS Symposium. So bearing that in mind, I'll remind everyone to please join us for today's keynote, which is next in our agenda, and will start at 11:45 a.m. Eastern Time. Please remember to use your join link to log on to the keynote. We're looking forward to having you join us for that, and enjoy the rest of your morning.